Hello friends, I am Dr. Nikita Pahwa. So let's study today one of the most important but understudied topics in obstetrics, that is prenatal and pre-implantation genetic testing. Let's begin with prenatal genetic testing. What is prenatal genetic testing? It gives parents to be information about their fetus that the fetus has certain genetic disorders. Now, what are genetic disorders? Genetic disorders are changes in a person's genes or chromosomes. One of them is aneuploidy. Aneuploidy is a condition where there is a loss of chromosome monosomy or extra chromosome trisomy. Other are inherited disorders that are caused by changes in genes called mutations. Inherited disorders include sickle cell disease, cystic fibrosis, Tay-Sachs disease, and many others. For them, carrier screening is done. Now, what are the different types of prenatal genetic tests? First is prenatal genetic tests, and second is carrier screening. First, prenatal genetic screening tests are done on the pregnant woman's blood and findings from ultrasound exams. They detect aneuploidy, neural tube defects, and some defects of the abdomen, heart, and facial features. The types of prenatal genetic screening tests are first trimester screening, second trimester screening, and combined first and second trimester screening, and fourth is cell-free DNA screening. Second is carrier screening. In carrier screening, blood sample or tissue sample is swabbed from inside the cheek to find out if a person carries a gene for certain inherited disorders. This can be done before or during pregnancy. Now, what are diagnostic tests? Diagnostic tests are done on cells from the fetus or placenta which are obtained through chorionic villus sampling, amniocentesis, or chordocentesis. Both screening and diagnostic tests are offered to all pregnant women. So let's begin screening of aneuploidy. Now, how is screening for aneuploidy done? It can be done by two methods, traditional or analyte based, and second is cell-free DNA based. Before we begin screening for aneuploidy, let's study what aneuploidy does. Aneuploidy accounts for more than 50% of first trimester abortions, about 20% of second trimester abortions, and 6 to 8% of stillbirths and early childhood deaths. Half of the abnormalities are trisomy 21. Trisomy 18 accounts for 15%, whereas trisomy 13 5%, and other sex chromosomal abnormalities account for 12%. The risk of fetal trisomy increases with maternal age, particularly after age 35. Now, there are some screening counseling elements. Friends, you need to remember that all pregnant women have three options: screening, diagnostic testing, or no screening or testing. The purpose of the screening test is to provide information, not to dictate a course of action. Diagnostic testing is safe and effective and provides information that screening does not. What is the difference between a screening test and a diagnostic test? Screening evaluates whether pregnancy is at increased risk and estimates the degree of risk. In screening tests, detection rate, false negative, and false positive rate are provided. Second thing you need to remember that cell-free DNA screening does not always provide a result. And importantly, irreversible management options should not be based on screening test results. With a positive screening result, a diagnostic test is recommended. So let's begin. First is first trimester screening, which is done usually at 11 to 14 weeks. The first part of first trimester screening is analyte based screening. Analytes are measured as a concentration, that is nanogram per ml, and then are converted to multiples of the median by adjusting for maternal age, maternal weight, and gestational age. Friends, as you can see in this table, the two analytes used in first trimester screening are HCG and PAPE. The level of HCG is increased in case of Downs and decreased in and levels of PAPA are decreased in Downs, whereas levels of both HCG and PAPE are decreased in trisomy 18 and trisomy 13. Second part of first trimester screening is knuckle translucency. Now friends, what is knuckle translucency? It is the maximum thickness of the subcutaneous translucent area between the skin and the soft tissue overlying the fetal spine at the back of the neck. See friends, as you can see in this picture, this is the soft tissue this is the skin which lines the back of the neck, and this is the subcutaneous tissue. What is the ideal time to perform knuckle translucency? It is 11 to 13 plus 6 weeks and CRL value lies between 35 to 45 mm and 84 mm. The lower limit, that is either 35 to 45, that varies according to laboratory. The cutoff for increased NT is more than equal to 3 mm. As you can differentiate these two pictures, that this is normal NT and this is increased NT. What the knuckle translucency has highest association with Down's syndrome. Other conditions associated with high increased knuckle translucency are other aneuploidies like 13, 18, exo, other cardiac anomalies, mostly septal defects, other genetic syndromes like Noonan's and Dijor's, and increased NT, that is more than 20% discordance in twins in knuckle translucency, is also prevalent in twin transfusion syndrome, that is TTTS. Now friends, what to do when you find increased NT? Now patients with increased NT should receive counseling and be offered targeted sonography with fetal echo. In addition, she should be offered prenatal diagnosis and cell-free DNA testing. Now friends, there is a USG criteria for measuring knuckle translucency. As you can see in this picture, that the image should be in the mid-sagittal plane, and image should be taken from inner to inner border. Head should be in a neutral position, measured in the widest area of NT. The amnion should be seen separately. An image must be magnified so that it is filled with fetal head, neck and the upper thorax. Important thing is that you need to differentiate NT from cystic hygroma. Now what is cystic hygroma? It is a venolymphatic malformation that appears as a septated hypoechoic space behind the neck, as you can see in this picture, and it extends along the length of the back. It is a marker of Down's syndrome in first trimester and Turner's syndrome in second trimester. Friends, both NT and cystic hygroma are risk factors for aneuploidy. Now let's go on to second trimester screening. Second trimester screening again has two parts, the quadruple or quad test or the quadruple blood test, and second is sonographic screening. The quad test is done from 15 to 21 weeks with a BPD value of 31 to 52 mm. As you can see that there are 4 analytes in the quadruple test: AFP, alpha fetoprotein, HCG, inhibin and unconjugated estriol. Now levels of HCG and inhibin are increased in Down syndrome, and AFP and unconjugated estriol are decreased in Down syndrome. Whereas in Edwards syndrome, the levels of AFP, HCG and unconjugated estradiol are all decreased. Second is the sonographic screening. Targeted USG between 18 to 22 weeks of pregnancy checks for major physical defects in the brain and spine, facial features, abdomen, heart and the limbs. Now what is neural tube defect screening? All pregnant women are offered screening for fetal open neural tube defects in the second trimester, either with MSAFP, that is maternal serum alpha fetoprotein screening, or with sonography. So let's study first what is maternal serum alpha fetoprotein. It is secreted by GIT, liver and yolk sac. The ideal time to perform MSAFP is 16 to 18 weeks and the cutoff value is more than equal to 2 to 2.5 multiples of the median. Now, what does increased MSAFP suggest? First, it is a screening for neural tube defects, but it is also associated with other fetal anomalies like abdominal wall defects, fetal death, and many other conditions which we are going to study later. Detection rate for NTD is at least 90% for anencephaly and 80% for spina bifida. Now, what is the next step if we see abnormal levels of MSAFP? First, we need to do USG to confirm the gestational age. Why? Because AFP levels start rising at 13 weeks and they peak at 28 to 32 weeks and then decline. That's why it is performed at 16 to 18 weeks where we have plateau levels. Second, we need to detect the anomalies. Third, fetal viability, because it is also increased in case of fetal death. And number of fetuses, why? Because source is fetus. For if there are twins or triplets, the level of MSAFP will be increased. Diagnostic tests are elevated what are the diagnostic tests after elevated AFP levels? The first thing we need to do is a targeted sonography, and second is increased acetylcholine esterase levels in amniotic fluid, which is the most specific test, but it is invasive. Now, sometimes what happens, there is high alpha fetoprotein level, but there are no anomalies and no chromosomal abnormalities. Still, there is still a high risk for preeclampsia, FGR, and IUD. Now, what is integrated and sequential screening? Friends, integrated screening is that combines first and second trimester tests. It is a combined measurement of fetal NT, that is knuckle translucency, and serum analyte levels at 11 to 14 weeks gestation plus quadruple markers at 15 to 21 weeks. Second is sequential screening. Sequential screening is of two types: stepwise sequential screening and contingent sequential screening. What is stepwise sequential screening? In stepwise, women with first trimester screen results that confer risk for Down syndrome above a particular threshold are offered invasive testing, and the remaining are offered second trimester screening. What do we do in contingent sequential screening? The patients are divided into three groups: high risk, moderate risk, and low risk. High risk group is offered invasive testing. Moderate risk goes for second trimester screening, and low risk they have negative screening, so there is no further testing. Now friends, this is a very important table which you need to remember. As you can see in this picture, that all the screening tests are judged on the basis of detection rate, false positive rate, and positive predictive value. Now, detection rate means the sensitivity of the test to detect the anomaly. False positive rate means the percentage of unaffected pregnancies that will be falsely positive. So, the detection rate or the sensitivity of quadruple screen, that is second trimester screen, and first trimester screen is almost same, that is 80 to 84% with a false positive rate of 5%. But the detection rate for integrated screening, that is combined first and second trimester screening, the detection rate increases to 94 to 96% with a false positive rate of 5%. The maximum detection rate for Down syndrome is with cell-free DNA screening, that is 99% of sensitivity and only 0.1% of false positive rate. Now friends, remember, NT or knuckle translucency is generally used as an isolated marker only in the screening for multifetal gestations. Why? Because serum screening is less accurate in twins. The NT distribution is similar in twins and singletons, but in twins, serum free beta HCG and PAPA levels are approximately double. Now there is unexplained abnormalities of first and second trimester analyte based screening. In first trimester, there is a significant association between serum PAPA levels below the 5th percentile and preterm birth, growth restriction, preeclampsia, and fetal demise. In second trimester, the positive predictive value of an elevated MSAFP value is only 2%. 98% of them have an etiology other than neural tube defects like fetal growth restriction, preeclampsia, preterm birth, fetal demise, stillbirth, and as we studied in previous slides, that it is also associated with preeclampsia, IUD, other fetal anomalies like abdominal wall defects, fetal death, etc. Now friends, what is cell-free fetal DNA? Now this test works by identifying DNA fragments that are derived primarily from apoptotic trophoblasts, which are placental cells undergoing programmed cell death. So the term fetal DNA is somewhat a misnomer. It can be performed anytime after 9 to 10 weeks gestation. Results are available in 7 to 10 days. Now what does it detect? It detects single gene disorders like myotonic dystrophy, achondroplasia, Huntington disease, CAH, cystic fibrosis, and alpha thalassemia. Friends, as you can see in this picture that this from the maternal circulation, the apoptotic trophoblasts are isolated and the DNA goes for real-time quantitative PCR detection in case of Rh genotyping, detection of single gene disorders, fetal sex determination, and massive parallel genome sequencing in case of aneuploidies. Now, what are the clinical applications? The first is fetal sex determination to detect an X-linked disorder. For example, in case of congenital adrenal hyperplasia, if we know the gender, then maternal corticosteroid can be avoided if the fetus is male. Second is RHD genotype evaluation. Fetal RHD genotype detection can prevent administration of anti-D in these pregnancies. With alloimmunization, early detection of Rh negative fetus might avoid the unnecessary MCA Doppler or amniocentesis. Now, what are the ACOG categories for high-risk pregnancy? High-risk pregnancy include women who will be 35 years or older, a positive first or second trimester analyte-based screening, sonogram with a minor aneuploidy marker, prior pregnancy with autosomal trisomy, and fifth, a known carriage, that is either patient or the partner of a balanced Robertsonian translocation involving chromosome 21 or 23. Now, cell-free fetal DNA is recommended for those at greater risk, and the categories I just told you now. Now, what are the limitations of cell-free DNA? Cell-free DNA is maternal and placental. So results may not reflect the fetal DNA complement. They may indicate placental mosaicism, maternal mosaicism, and or maybe an early demise of an aneuploid co-twin. In twins, cell-free fetal DNA is not recommended because of limited efficacy. Third limitation is assay failure, high assay variance, or maybe low fetal fraction. So it can be undetected in 4 to 8% of pregnancies screened. Now friends, pretest counseling should include the possibility of a low fetal fraction or no call result and its clinical significance. Now, how can we compare cell-free DNA testing with analyte-based screening? First, there is a low likelihood of false positive results in case of cell-free DNA, as we saw that the sensitivity of cell-free DNA was 99% with the false positive rate of only 0.1%. Second, analyte base are frequently positive with a large range of chromosomal abnormalities, whereas cell-free fetal DNA screens are specific for individual aneuploidies like autosomal trisomies 21, 18, Turner, and other sex hormone aneuploidies. Now, what is sonographic screening? The sonographic screening is the second part of second trimester screening. Now, it can augment the aneuploidy screening by detecting multifetal gestation, by providing accurate gestational age assessment, by identifying major structural abnormalities and minor sonographic markers. Now, friend, it is not an alternative to prenatal diagnostic tests, which we are going to study later, but the risk increases with if additional findings are identified in sonography. Now, what are the some second trimester soft markers? Knuckle skin fold thickness more than 6 mm, echogenic intracardiac focus, mild renal pelvis dilatation like 4 which is more than 4 mm in second trimester and more than 7 mm in third trimester, echogenic fetal bowel, short femur, short humerus, clinodactyly, sandal gap, nasal bone absence, single transverse palmar crease. Now, minor marker is identified. If a minor marker is identified, then we offer aneuploidy screening. If cell-free fetal DNA screening is already performed before, then negative, the risk is not modified if a minor marker is positive. Now, how do we do carrier screening for heritable genetic disorders? What are the heritable genetic disorders? Cystic fibrosis, spinal muscular atrophy, sickle hemoglobinopathies, and thalassemia. For cystic fibrosis, ACOG recommends that all patients who are considering pregnancy or are pregnant should be offered carrier screening for cystic fibrosis. If both parents are carrier, then chorionic venous sampling or amniocentesis can help determine whether the fetus has inherited one or both of the parental mutations. Second is spinal muscular atrophy. It is an autosomal recessive disorder. There is no effective treatment. Again, ACOG recommends screening of spinal muscular atrophy to be offered to all pregnant women. Third is sickle hemoglobinopathies. Now for sickle hemoglobinopathies, we offer hemoglobin electrophoresis, and if there is risk seen, then prenatal diagnosis is done. Fourth is thalassemia, which is the most common single gene disorder. Detection of alpha thalassemia is based on molecular genetic testing and not by electrophoresis. So friends, if there is microcytic anemia in the absence of iron deficiency and electrophoresis is normal, then testing for alpha thalassemia is considered. For beta thalassemia, electrophoresis with HbA2 more than 3.5 is diagnostic.